Perfect. Welcome everyone to the Pediatric Aerodigestive Lecture Series, and we're extremely excited that you have joined us and hope that we can have community connection and collaboration as we enhance the future of pediatric care. This is the fourth lecture on our series, and we are happy today to host the pediatric GI and pediatric surgeon who's actually going to take us through how they work together in their centers to expand pediatric aerodigestive care. And we hope that we can learn a few things here together. We're happy for you to have questions in the chat. Just a reminder, the sessions are held every 2 weeks on Zoom at 7 p.m. And the remaining bits of this will be anesthesia and a patient or representative of a patient about pediatric aerodigestive care. So without further ado, I will introduce our first speaker today. Dr. Shelly Choudhury is a pediatric gastroenterologist who cares for children with digestive illnesses. She has special interest in eosinophilic gastrointestinal disorders, inflammatory digestive tract conditions linked to food allergies, and aerodigestive disorders. In research, Dr. Choudhury has studied non-invasive techniques for diagnosing eosinophilic esophagitis, which is an allergic condition of the esophagus, as well as new treatments for the disease, including biologics like medications derived from living sources. She earned her degree from Neil Ratan Sarkar Medical College and Hospital in India. I'm not sure if I've done justice to this name. And she completed her residency in pediatrics at Bronx Care Health System and a fellowship in pediatric gastroenterology at University of Buffalo. So, Dr. Shelly, you are very welcome. We look forward to your talk and to learning from you. Thank you.
Thank you for that kind introduction, and I'm excited to be here and discuss our GI perspective and what we do here at UCSF for our aerodigestive children or children who present to our aerodigestive clinic for coordinated care. And I'm gonna start sharing my slides. Okay. Again, so today we are here to discuss what happens from the GI perspective. And I have no disclosures to make today. So our learning objectives today will be first to know who are the patients that present at our aerodigestive clinic and what do we do as a part of the aerodigestive medicine. What are the common GI complaints that we see in this clinic and how that overlap with the other specialties? And also how, as a team, we can do a coordinated evaluation and also how patients benefit from this approach of coordinated care. So what are aerodigestive disorders are basically their combination of a multiple interrelated either congenital or acquired conditions that affect the airway, breathing, swallowing, or growth that require a coordinated approach so that we can achieve optimal outcomes. And as you can see in this picture, or the anatomy just shows how the mixed airway and the proximity of the gastrointestinal tract side by side. And some of the most common conditions that we see presenting to us are oropharyngeal dysphagia, aspiration, chronic cough, GERD, or gastroesophageal reflux disease. So mostly the kids who present to us, and if we were to divide it team-wise or organ system-wise, for GI, mostly what we see is they have feeding difficulties or coughing or choking while feeding. A lot of them have texture limitations or pathologic regurgitation, which will be, beyond the normal amount of regurgitation, or even presenting with food impaction, requiring compensatory mechanisms for swallow. Also, postural changes while eating, or some of the symptoms that can be accompanying and maybe not so discreet will be like weight loss, poor weight gain, or even like prolonged meal duration. The colleagues from our ENT and pulmonary side, which you may have already heard from them, from their perspective, what they see is complaints of food spillage from lips, drooling, nasal regurgitation, chronic congestion, or changes in the voice, articulation, speech, or also accompanied by noisy breathing or stridor. One of the very common complaints that we deal together from the pulmonary side is chronic cough, repeated bronchitis or pneumonia, or worsening pulmonary function. So the aerodigestive conditions just basically represent the extraesophageal manifestations of acid reflux. We also kind of revolve around like the pathophysiology and the biological plausibility of these conditions with acid reflux. And we will also learn about today what are the current evidences and in what situations we use PPI to treat aerodigestive diseases. So talking first about oropharyngeal dysphagia, one of the most common complaint that we see in the aerodigestive clinic. So what is essentially oropharyngeal dysphagia? So we know that swallowing involves a conscious and semi-automatic system and a precise coordination of the oral and pharyngeal muscle groups. And the oropharyngeal dysphagia just kind of implicates the location of the difficulty to be the oropharynx and the process involved in this phase of swallowing. And just to illustrate that in a more vivid pictorial way, I have this video for 2 minutes that I'm gonna play.
With a normal swallow, food and liquids move from the mouth into the esophagus directed by a precise sequence of coordinated muscle movements. In order to adequately describe the biomechanics and bolus movement during swallow, the 4-stage model was developed. Let's slow down the animation in order to more clearly appreciate what happens during normal swallow. The 4 stages are as follows: oral preparatory stage, oral transit stage, pharyngeal stage, esophageal stage. During the oral preparatory stage, food is kept in the front part of the mouth where it is moistened with saliva and chewed into a softer consistency. Once the food bolus has been processed by the mouth, the oral transit stage begins with the tongue raising up against the hard palate while the back of the tongue drops to allow the bolus to move into the back of the mouth. Simultaneously, the soft palate raises up against the back while closing off the passageway into the nose, preventing any food or liquids from regurgitating back up into the nose. The pharyngeal stage is a rapid sequential activity during which the bolus is propelled into the esophagus. The larynx elevates while the epiglottis flips down, protecting the airway. Not clearly shown are the pharyngeal muscles which contract, squeezing the bolus downward. The cricopharyngeus muscle, or upper esophageal sphincter, relaxes and opens to allow food and liquids to pass into the esophagus. Once the bolus passes the cricopharyngeus muscle, the esophageal stage begins. The cricopharyngeus muscle closes back up to prevent any regurgitation back up into the throat. The esophageal muscles continue to propel the bolus into the stomach by a coordinated muscle contraction and relaxation known as peristalsis. The mouth and throat resets to prepare for the next swallowing event. Should there be any deficits or coordination problems at any point during the 4 stages of normal swallow, choking, aspiration, nasal regurgitation, or even the complete inability to swallow may occur.
So yeah, so as you can see how nicely this video kind of highlights the intricate process and the coordination of all the muscles involved and the proximity of the airway or the interplay of the airway and the digestive tract. So moving on.
With a norm.
Yeah, so I just wanted to go over some of the major complaints or the symptoms or the conditions that we see and how they overlap with the reflux, because that's kind of always the major question or concern, whether this is all about reflux or there is something else behind it and should we be treating reflux or not. So looking into oropharyngeal dysphagia and reflux, there is a prospective study that was done from Boston of 108 subjects, and they were all under 18 months old, presenting with feeding difficulties. And they administered two kinds of questionnaire for their patients. One was the infant gastroesophageal reflux questionnaire, revised one, and then the pediatric eating assessment tool, number 10. And what they saw was both of these sort of highly correlated with each other. And also, there were about 71% of the subjects who had a video fluoroscopy swallow study done, which also correlated with higher score. It just tells us that, whenever we are seeing this eating disorder or the dysphagia, there can be a big overlap. So not necessarily it's the reflux situation. And when they also kind of like broke down into like the questions that were asked, they saw the blue spell questions on the GERD questionnaire had a relative risk of 1.148 for predicting aspiration or penetration on the swallow study with 100% specificity. Again, kind of like highlighting the overlap between the two. Scores on the question regarding crying during or after feedings were also higher in subjects with abnormal swallow study. Again, highlighting that dysphagia can be, presenting or there can be like a presumption of reflux for patients who originally is having oropharyngeal dysphagia. We have also known from different studies so far that the reflux does occur about 8.8 to 26% of children with aerodigestive issues, especially who have asthma or has a history of tracheoesophageal fistula, esophageal atresia, and in about 26 to 70% in children with neurological impairment. So there was another study with a similar group from Boston who looked into respiratory symptoms and reflux. And their main aim was to look into pH probe with impedance and evaluate these children who presented with respiratory symptoms. The main presenting symptom for these children in the aerodigestive clinic were cough, desaturations, tachypnea, wheezing, breath holding, and grunting. And in this retrospective study of 28 children, they found out that the total of 130 respiratory symptoms were associated with reflux, either through the pH impedance probe or just the pH probe. The mean of the age of these 28 children was about 6.5 to 5.6 years. But they also noticed that the non-acid reflux were highly associated or correlated with the reflux symptoms rather than the acid reflux. And that's why the utility of the pH probe with impedance, which is able to detect the non-acid reflux, came in picture. What they also noticed was, apart from the non-acid reflux being more prominent with the events, it also looked into the height distribution, meaning like how far the acid or the non-acid reflux had went all the way into the esophagus. And this can be determined by the channels of either the pH probe or the pH impedance probe exam that you're doing. So they also saw that the non-acid reflux reached a higher height, almost to the proximal esophagus, in about 70 or 75.3%, whereas acid reflux were predominantly distal esophagus. Next, about, again, overlap or the association between asthma and reflux. So again, we do see a lot of kids where, if they are not in their digestive clinic and they are separately seeing a pulmonary and separately seeing a GI, there is always this, kind of like disconnect in the treatment, whether, okay, asthma is not responding to usual treatment, and they go on PPI, and then they come to GI, and then we are wondering like, well, is this really necessary? Is this really improving their asthma symptom? Is this reflux at all? So there are some studies that have looked into it, and there's like two main theories that are in place. One is the reflux theory, and the other one is the reflex theory. So reflux theory just says that, this acid reflux is directly producing airway inflammation and airway hyperresponsiveness, versus the reflex theory suggests that if there is acid reflux, there is a vagally mediated bronchial or laryngeal spasm that contributes to the respiratory distress, and it can be also a neural or neuronal mediated inflammation, as opposed to acid directly causing the damage. And then there is the other thing, whether the opposite or the vice versa, whether there is asthma has an impact on GERD. So which led to what? So which came first? So essentially, if there is chronic hyperinflation going on from asthma, there is elevated intra-abdominal pressure, and that may in turn reduce the LES or the lower esophageal sphincter pressure and can lead to increased episodes of acid reflux. And the lung hyperinflation and airway flow obstruction can also increase negative intrathoracic pressure. So that will kind of alter the crural diaphragm gastric esophageal junction relationship and promote reflux in that way. There is a study which is a systemic review of 12 observational studies by Hamed et al. This year, which looked into this association between childhood asthma and GERD in children. And they saw that the GERD in asthmatic children range from anywhere between 0.7 to 65.3%. And the total prevalence was about 3.6%. But what they also saw was obesity in asthmatic patients were an independent risk factor for the incidence of GERD. But there was no direct evidence or no any way to conclude that, one is a cause of the other. Next, about other, when we see these children with aerodigestive issues coming to the clinic, they do have a lot of airway issues. Some of them are ventilator dependent, some of them tracheostomy dependent. So to understand the relationship between this kind of ventilation and what it does to our GI tract, or essentially reflux part of it. So understanding that physiology is kind of important. So when a patient is on non-invasive ventilation, it sort of prevents the bronchus and the tracheal lumen from collapsing. So it actually, and also it's shown that their swallowing and their digestive protective reflexes are preserved. So for those patients, oral feeding is not really a contraindication just because they are ventilation dependent. Same for the tracheostomy tube, but obviously we have to be a bit more cautious before we start oral feeding in patients such as this, and generally, study or evaluation by the swallow therapist is recommended before going that route. We also know that CPAP or continuous positive airway pressure increases the ileus or the lower esophageal sphincter pressure as well, more than the stomach pressure. So it prevents actually from GER from happening. On the other end, or if we are concerned, or if there is a concern of reflux or regurgitation that's not under control, that will be a contraindication for non-invasive ventilation because of the aspiration risk. And also, like if there are patients who have a lot of gastric distension or aerophagia going on, that will be also kind of have to be taken into consideration when we are looking at the ventilation part of it. Next, about another airway condition and its overlap with reflux, and that's laryngomalacia. So a lot of scientific research has supported that gastroesophageal reflux does contribute to laryngomalacia through the irritation of laryngeal mucus. The other way is true as well. The laryngomalacia leads to reflux by increasing the negative intrathoracic pressure. Again, just like asthma, as we just saw, and other respiratory symptoms, the exact pathophysiological relationship is not known. So there is no recommendation in place or rationale for the use of anti-reflux medication. The supraglottoplasty is an effective treatment option for laryngomalacia. However, again, my colleagues, when we work together with our ENT colleagues, we have to be like very cautious and be cognizant about the reflux part, or if there is any uncontrolled regurgitation, because that will lead to poor outcome of the supraglottoplasty and may end up doing another revision. And that's why the International Pediatric Otolaryngology group guidelines recommend the use of empiric acid suppression if the patient is also having any feeding or respiratory difficulties prior to supraglottoplasty. So another entity called the laryngopharyngeal reflux, again, it's substantially part of the extraesophageal manifestations of GERD that we kind of mentioned in the beginning, that we were mainly looking into. And from the ENT perspective, this is an independent upper airway disorder caused mostly by non-acid contents like bile, pepsin, and trypsin. Just like we have seen in that other study when they, probed into the respiratory issues, they found that it was more correlated with non-acid as opposed to acids. And the usual findings that they see from their exam or a FEES exam will be like self-glottic edema, erythema, inflammation, ventricular obliteration, vocal fold edema, tissue hypertrophy, granulomas, and excess laryngeal mucus. And again, this is another picture just kind of describing, kind of like those edema, cobblestoning, erythema, if you can see in this region. So kind of like signs of irritation, which leads to the diagnosis of this LPR or laryngopharyngeal reflux. From the ENT perspective also, they don't have very specific criteria or investigational tools for this diagnosis. So this is another condition which is kind of like, starting off with empiric treatment with acid suppression and, seeing how the patient improves, and if not, kind of like going down the route for investigations versus other treatment. There's another study which did a systemic review of the airway findings in children with GERD. And what they found was some of the features really or strongly correlated with GERD, and that was the posterior glottal edema and erythema, and the vocal fold edema and nodules. So those are some of the things that are, kind of correlated in their findings. I briefly also wanted to talk about this brief resolved unexplained events, which were formerly called ALTI, or apparent life-threatening events. As you know, that BRUI is defined as an event occurring in an infant less than 1 year of age, where an observer reports a sudden, brief, and resolved episode of one or more of the following, which is cyanosis or pallor, absent, decreased, or irregular breathing, change in tone, altered level of responsiveness. And I highlight this in this slide just to kind of bring the recommendations from AP, where it is suggested or recommended that the clinicians should not obtain investigations for reflux for BRUI or ALTI. And those studies will be upper GI, pH probe, endoscopy, barium study, or nuclear medicine study or ultrasound. And then kind of summarizing the 2018 NASPGHAN-ISPGHAN guidelines to treat pediatric reflux in clinical practice. And again, a lot of this is done, in collaboration with our dietitian, our speech and swallow therapist, who kind of like guide the patients or the moms to kind of like go through this step by step. So if there is a suspicion of GERD after the history and physical exam, if there is no alarming signs, then generally the recommendation is avoid overfeeding, thicken feeds, and you can continue breastfeeding. If there is still no improvement, then the next line of care will be like a 2 to 4 weeks of a trial of a hydrolyzed formula. And in breastfed babies, it can be like elimination of dairy from maternal diet. And again, if not improve, then referral to pediatric GI. And if the referral is not possible, then you can try a trial of 4 to 8 weeks of PPI. From our perspective, we have to revisit the differential diagnosis, and then, depending on the symptoms and the alarming signs, considering other testings. Investigational tools. So what we do as a group is what we call triple endoscopy. So we go in to do our endoscopy with the biopsies, while our ENT and pulmonary colleagues also join for their part of bronchoscopy and laryngoscopy as well. So we can get it done at one setting, minimizing the risk of anesthesia or several episodes of anesthesia. And kind of like have a discussion of the findings right there, which is kind of like super helpful for the patient care, going forward. And as I mentioned before in one of the earlier slides, that about 36% of aerodigestive kids have abnormal histological findings like esophagitis, gastritis, EOE or eosinophilic esophagitis, and duodenitis. And also some of the kids that are at risk would be children who has had esophageal atresia, or also kids with TA for tracheoesophageal fistula undergoing surgical repair can develop EOE early on. The other studies that we could do is manometry to kind of understand the motility of the esophagus or the sphincter pressures, kind of having an objective measurement of those. And the other ones would be the pH monitoring, and the one with impedance will also give us idea about non-acid, air, gas, liquid, so all of those solvents. EndoFlip is another tool that can be used for dilation, for a measurement of the distension of the esophagus, also kind of like the propulsive movements. And then similarly, high resolution pharyngeal manometry, just like the term says, pharyngeal. So it's really for the upper airway, kind of very similar to the pH monitoring, but the probes are situated over in the pharynx. The only downside of this testing is because there is no solid baseline data, it's hard to conclude whether studies are normal or abnormal. T&E is another newer tool that is coming into practice. The transnasal endoscopy essentially is a smaller diameter scope, or similar to like the pulmonary scope, that can be used nasally to do the endoscopy without anesthesia, just with local sedation. It's pretty quick, and biopsies can be also obtained. So this is something that can be done in an outpatient setting in the clinic itself, which cuts down the visit time and also spares an event of anesthesia for the kids. So coming to treatment strategies, we saw like how non-acid reflux is important part of, association of the respiratory symptoms and others. So acid suppression has minimal impact on those. Baclofen has been studied a lot to help in preventing acid and non-acid reflux, because it has the properties to inhibit ileus relaxation. But studies have not been super promising in terms of like efficacy. It's kind of so it's not like something strongly recommended, also because of the worrisome central side effects that can come with it. Alginate is out there. We haven't commonly used it. This is something, again, reported in the literature. This is that can form like a mechanical barrier and inhibit the pepsin and the bile acids. There's some randomized controlled trial, but again, more research needed to implement that in practice. There's some newer agents like trypsin inhibitors and other agonist or antagonist that are being looked into. The pro-motility agents have not been specifically studied in this context of especially the non-acid reflux, although in clinical practice for regurgitation, sometimes they are used, but again, there's no strong recommendations against or for it. So if medical management fails, more aggressive therapies will be going towards jejunal or small bowel feeds or fundoplication. So the non-pharmacological options we have either gastrojejunostomy tube or nasojejunal tube, or just a direct J or jejunostomy, essentially all kind of like post-pyloric feeds. It may be beneficial to prevent like things like apnea, bradycardia, but not obviously 100% able to prevent aspiration pneumonia, or the reflux volume will be decreased but not eliminated. And there are obviously other complications that come with it, like dislodgement, site complications, possibility of intussusception with gastrojejunostomy tube. So the surgical option is fundoplication, which our colleague will discuss more about this. And then there are obviously some side effects or complications that can also come along with that.
Sorry, Shelly. I think just in the interest of time, I want to make sure Sarah has enough time to present her case.
Oh, yeah,
we're going to go until 10:15 with questions. I'm not sure how many slides you have left, or if perhaps on this topic she could address it.
Sure. I think this one, and yeah, this is kind of like the last one.
Okay, thank you. Great. It's yeah, this has been a great talk so far. Thank you.
Yeah, sorry, I don't have a clock. I was also wondering the same, but thank you for the reminder. So yeah, this last study that I was going to discuss was about the fundoplication versus the use of gastrojejunostomy tube, and they again did not see any big difference in terms of pneumonia, mortality, or procedural complications. So again, one was not recommended over the other. And then these are kind of like some of the devices that are used in the adult world for reflux, but we typically don't use it in kids. I just put up a picture there. And then lastly, kind of highlighting the study that was published in JPGN about pediatric aerodigestive medicine and how collaborative care helps for these complicated patients who have, complex medical conditions presenting with GI issues, pulmonary issues, ENT, and where with our speech pathologist or SLP and the dietitian, we can do kind of like a collaborative management and sort of like improve the care of the kids. So that will be all. These are my references and questions. I'll stop sharing now.
Thank you, Shelly. That was amazing. And I have some questions for you, but we'll let Sarah go first so that we can have questions at the end, if that's all right with you.
Yeah, absolutely.
Thank you. So our next speaker is Dr. Sarah Cairo. She's a pediatric surgeon with training in minimally invasive procedures for newborns and children. She's interested in improving access to care for pediatric patients with complex colorectal diseases and creating teams to meet their needs. She's part of this UCSF Center for Health Equity in Surgery and Anesthesia, and Dr. Cairo's research focuses on improving access, both domestically and internationally, to general medical care and surgery, as well as improving the quality of these. She also studies transitions in care for kids who need surgery. She has received grants for her work in surgical education and global health, specifically for examining pediatric surgical capacity in the Democratic Republic of Congo. Dr. Cairo earned her medical degree at Tufts University School of Medicine. At Tufts, she also earned a Master of Public Health degree that focused on infection control and sexual health in criminal justice system, go girl, and on human trafficking and women's health. She completed her residency in general surgery at Maine Medical Center and a fellowship in pediatric surgery at the University of Texas Southwestern Medical Center. So I'm excited to introduce her, and I will hand over to you, Sarah.
Great. Thank you, Fiona. So I was going to provide a surgical perspective on some of these things. Obviously, the topic of aerodigestive disorders is quite broad. And I think, as we just heard, there's a huge amount of overlap between sort of ENT, GI, and surgery. For the sake of time, I was going to sort of narrow my focus to really the reflux diseases and how surgery is involved and can care for those. We could spend hours talking about the other things that we help with, the tracheoesophageal fistulas, the tracheomalacia, and things where we get involved. But again, for the sake of time, we'll focus on reflux. I have no disclosures. So picking up from where we just left off, I thought I'd start with indications for surgery. So we just heard about the workup of a lot of the various ways that GI is involved in aerodigestive disorders, but specifically with reflux. And so when we start talking about surgery, there's obviously some controversy and variability in the management, and a lot of the symptoms that we're treating are subjective. So we've gone through the diagnostic approaches and the indications for performing those various tests, and then a little bit about how to interpret them. And when we're evaluating response to therapy, there are options for repeating some of these quantifying studies, but more often than not, we're talking about general symptom control. So when we start talking about surgical management of reflux, that's theoretically when medical therapy has failed, when there are specific anatomic causes for the reflux, such as a hiatal hernia, or when there are complications of reflux. So medical failure is defined by persistence of symptoms despite maximal medical therapy, or in pediatrics defined as can also include poor weight gain or failure to thrive. The complications that we referred to and that we heard a little bit about are things like esophageal damage and reactive airway diseases, or ALTIs. And the indications for surgery can further be divided into some other categories. And so when I talk to families about the indications for surgery, I try to think of it, are we treating symptoms? Are we treating signs? Or are we treating complications? So when we start with symptoms that we would use surgery to treat, starting with the most common in the setting of GERD, we have heartburn, so the obvious symptom, dysphagia, dynaphasia, food refusal because of that pain. We talked about the airway diseases, so apnea, these ALTIs, reactive airway diseases, or recurrent pneumonias, patients with upper airway symptoms, and then patients with such bad reflux that they have dental erosion or other complications. When we talk about, so the symptoms are what the patient experiences, and that may lead us to recommend a surgical intervention. The signs are the actual findings or objective pieces of data that support the need for an operation. So things like reflux esophagitis, which can be due to the gastric acid, pepsin, and bile salts coming into contact with the esophageal mucosa. And what we find is that damage to the mucosa with mucosal breaks is found in about 30 to 40% of patients with severe reflux. Barrett's esophagus is the other one that we'll get into a little on the next slide, but it offers actual histologic evidence of the presence of longstanding GERD and also poses an increased risk of malignancy. So as most of you are probably familiar, there's limited data on the long-term complications of GERD in childhood, but we do extrapolate some from the adult population, including our understanding of things like Barrett's esophagus. So Barrett's is defined by the presence of the salmon-colored mucosa in the tubular esophagus, extending at least 1 centimeter above the GE junction, with histologically confirmed metaplastic columnar epithelium. Barrett's esophagus is significant in that it is the primary risk factor for esophageal adenocarcinoma and requires different strategies for management and for surveillance. Unfortunately, the actual prevalence of BE in children is unknown. There was a 2018 systematic review of BE in the pediatric populations where 80 patients were identified as having confirmed BE. A quarter of those patients were neurologically impaired. 16% had a history of esophageal atresia with or without a tracheoesophageal fistula, and a number of other patients had other associated conditions. And so from that, they estimated the prevalence of BE to range from 0.05 to 4.8% with a mean age of 12.4 years at time of diagnosis. This is a huge range, and obviously these are young patients. So given the lack of data on this topic, practice guidelines are typically modified from the adult literature, with recommendation screening in men with 5 or more years of reflux being modified based on the patient age. The risk of progression to cancer in patients with BE is 0.2 to 0.5%, and increased to 6% per year if they have high-grade dysplasia. So the goal of endoscopic surveillance is to detect this dysplasia at an early age and manage it. There are some alternatives to biopsy that are being studied for diagnosing Barrett's, things like white light endoscopy and dye-based chromoendoscopy, but these are pretty limited in the pediatric population. So for now, we stick with endoscopy. And again, I'm not going to get into it too much, but in these higher risk populations like the neurologic impairment and the TEFs, we do have more specific guidelines for when they need endoscopic surveillance, and this kind of feeds into that transitions in care because we lose contact with a lot of these patients once they reach adulthood, and sometimes even teenage years, just because they're no longer having any issues and they can get lost to follow-up, but they are at high risk for these sorts of complications. Moving on from signs, there are also diagnoses that may serve as an indication for surgery. And these include things like neurologic impairment. There's a lot of debate about the role of acid-reducing surgery in the setting of neurologic impairment, kind of like in the setting of the respiratory patients. And one of the limitations is that the risk of aspiration in neurologically impaired children is not necessarily due to reflux. And this is a difficult conversation that I have with a lot of families and a lot of providers, and that a lot of these patients, their feeding difficulties are oropharyngeal. They're based on their swallowing. And in the setting, and some of them even have impaired esophageal motility related to that. And in the setting of impaired esophageal motility, and if they have other bowel dysfunction, constipation, other motility issues, their risk of aspiration may actually be worsened by an acid-reducing surgery or a fundoplication, because you're creating that sort of mechanical blockage. So all that saliva that they're already struggling to get into their esophagus is now struggling to go through, and they're more likely to have reflux. These oropharyngeal issues are present in more than 90% of neurologically impaired children, and in at least 15% are classified as severe. And so anytime I get a consult for an acid-reducing surgery in a patient who has gagging or retching or signs of esophageal motility, those are the patients who we need to be really aggressive in our diagnosis of their reflux and understanding what their anatomy is like. Next one we'll talk about is obesity. So over the past few decades, obesity and associated reflux has increased in all age groups. The pathophysiology behind this relationship lies in the fact that obesity is generally associated with increased transient lower esophageal sphincter relaxations and higher intra-abdominal pressures. Obesity can also contribute to reflux symptoms through a state of chronic low-grade esophageal inflammation. Again, but this can be associated with increasing intra-abdominal pressure. Esophageal anatomic disorders is an area of particular interest to us as surgeons. The anatomic disorders may increase the need for anti-reflux procedures or increase the likelihood of a successful anti-reflux procedure. And examples of this will be patients with hiatal hernia or with the history of esophageal atresia. Chronic lung disease or history of lung transplant is another diagnosis where this may be more important. So, for example, patients with cystic fibrosis, GERD is associated with accelerated decline in lung health in children with CF. And in a systematic review of the literature, 59% of patients had reduction in symptoms and reduction in decline in lung function and decline in number of pulmonary exacerbations with improvement in respiratory function only in milder cases of CF. The consensus from these data, though, is limited and heterogeneous, and as in most things, is especially limited in the pediatric population. So they do support the use of acid-reducing surgery to slow the deterioration of lung function in patients with CF, but there's need for a lot more research in this. And then, as we talked about, the relationship between asthma and GERD is kind of poorly understood. There's a lot of different theories. Another thought is the fact that the vagus nerve innervates both the esophagus and the bronchial tree, and so inflammation with one can cause inflammation of the other or changes in the other. And again, this is kind of a chicken and an egg thing, because while asthma, similar to obesity, is thought to be a risk factor for GERD, the surgical management of reflux is thought to help improve the asthma, but with that, the vagus nerve and the other theories behind this that we just spoke about, it's not clear which one is causing which, and if the fix will address both. And then finally, prematurity. This one I should put an asterisk by, because a lot of these patients, almost all of them will have reflux, but a lot of them will grow out of it. And so this is another population where when we start talking about doing surgical interventions, we try to think about reversibility and how long do we expect this patient to have their problems. And as our GI colleagues know, a lot of patients will grow out of their reflux, a lot of the premature babies. So now that we have a general idea of how to diagnose the patient with GERD and determine when we think an operation may be indicated, we'll talk about the options and how we might approach a surgical intervention. So from a historical perspective, the original anti-reflux surgery was the Allison procedure, which involved reconstruction of the hiatus and the setting up a herniated viscera in people with symptoms such as growth restriction, aspiration pneumonia, and vomiting. Through a series of refinements and modifications, this has led us to the contemporary hiatal hernia repair and fundoplications. As the most talked about procedures for reflux, especially in the pediatric population, we'll dive into the fundoplications in a little bit more depth. So the first step is deciding what kind of fundoplication we want to do. The most common is the Nissen, which is described as a complete 360 wrap of the fundus. You make a neck of about 2 to 3 centimeters. The main limitation of the Nissen is the risk of postoperative dysphagia from the wrap being obstructive because it goes all the way around, or from anterior displacement of the esophagus above the GE junction and risk of recurrence. The thal fundoplication, on the other hand, is a 270-degree anterior wrap with sutures to the crus compared to a door, which is also an anterior wrap, but only 180 degrees. There we go. In a randomized study comparing the Nissen and the thal at a single institution, they found no statistically significant difference in Nissen versus thal with respect to conversion to open and short and long-term outcomes. They did find a higher rate of esophagus, a higher rate for severe dysphagia in the Nissen group and need for additional procedures. But most of the other complications were related to the G-tube or other things that were done. And in contrast to the Nissen and the thal, the toupee, you can see in the bottom right corner, is a 270-degree posterior wrap. This results in a partial obstruction and displacement anteriorly, but has a lower risk of esophageal dysmotility. So in a patient who has that sort of dysphagia and maybe, again, some actual esophageal dysmotility, doing one of these partial wraps can be more beneficial, but then it may not be giving you the same impact on your reflux symptoms. And so this is, again, just a systematic review and meta-analysis comparing partial versus complete fundoplication for the correction of pediatric GERD. They only found 2 RCTs and 12 retrospective cohort studies for the review, and overall found no difference in successful management of reflux symptoms between partial and complete fundoplications. Many of the studies described objective assessments for the operation, and one study using one of these objective assessments, which is something like the EndoFlip, which can be used intraoperatively to actually show a change in your reflux. And that one did show improved outcomes after the complete fundoplication. Several complications were also described, but because of the heterogeneity and kind of poor quality of a lot of these studies, it's a little bit difficult to ascertain and to actually compare results, because some of the patients had neuromuscular delays, some needed tube feeds, some were premature, and as we've talked about, those all have an impact. So let's say we decide we want to do some sort of fundoplication. We pick which one we think makes the most sense based on the presence of dysmotility and other things. So now we need to decide how we want to do it. Historically, this is an open procedure, but we've made a lot of advances and a lot of changes in surgeon skill and have now added this option of minimally invasive or laparoscopic surgery. And there are even places doing single site or natural orifice or endoscopic approaches to fundoplication anti-reflux surgery. I'll go through a couple of the ones that Shelly mentioned, but these are not popular in the pediatric population for obvious size limitations of the equipment that I'll show. There are a number of systematic reviews looking at the topic of laparoscopic versus open fundoplication, specifically in the pediatric population. And there's some that look just at cardiac patients, just at cystic fibrosis, neurologically impaired children, children who've had other operations, and a couple other specific scenarios. They're not, however, a robust set of data from RCTs, because with our randomized control studies, which are really difficult to do in the pediatric population. As you can imagine, it's hard to recruit families to do that. And a lot of what we do as surgeons is based on our experience and our familiarity with techniques. So while I might love to do a laparoscopic Nissen and can do it in under an hour, it might take me a lot longer to do it open, and I have partners who are the opposite. So asking surgeons to be randomized to a technique that they're not as familiar with will obviously have a change in the the outcomes. So in one of these studies, they did find that the Lap-Nissen was found to be as effective as open in short and long-term management of reflux, but that both procedures were associated with high risk of recurrence and mortality, especially in those neurologically impaired patients and in younger patients. And then in another study, Lap-Nissen is described as being safe, feasible, and effective alternative in children, with the advantage of less total post-op complications. And some talk about less retching and airway complications, but a lot of it has to do with technique. And as you can see here, a lot of factors influencing the decision-making behind this. Oops. And then this on the right is just showing over time how laparoscopic has really increased in popularity, and now the majority here are being done laparoscopically. This does add some extra challenges, especially when most of these patients have cardiac issues and don't tolerate pneumoperitoneum so well. So we're working in a very tiny space with very minimal insufflation, which leads us to wondering, are there other things we could do? So taking it one step further on the minimally invasive route, we have the transoral incisionless fundoplication. This procedure is really cool, but again, not totally relevant to our populations, unfortunately. So in this procedure, there's multiple non-absorbable polypropylene fasteners that are deployed through the esophagus and stomach in a 270-degree circumferential pattern to create that 3 to 5 centimeter long valve at the level of the G junction. So basically creating that Nissen. There's a couple small studies looking at this, and some of them report a high recurrence rate, but most of the high recurrences are in patients who otherwise would be expected to have a high recurrence. And I'll see if I can just show part of this. Oops. We'll give it one more try. Otherwise, I can share it. I'm going to skip the rest of that for the sake of time, but it's pretty cool. And again, I can share that link. There's another endoscopic approach that is also not used so much in pediatrics just because of size limitations, and this is the Lynx device. We were using this in adults, but there were some issues, and I feel like in my training I removed more of these than saw them put in. But this is basically a magnetic sphincter augmentation system that is thought to be useful in the treatment of refractory or chronic GERD. There are some studies that compare this to a Nissen and found the Lynx to be statistically superior in the preservation of the ability to belch and vomit, which is an area of concern for a lot of patients as they get the gas bloating and issues after a Nissen, but here they were showing that this has a better outcome with it. Thinking about outcomes of Nissens, so there are a number of studies exploring the results of Nissens in different patient populations, and this is going to be very broad because, again, all of these patients are different, and so they will have different outcomes. Many of the times that we're doing these Nissens, we're doing this in combination with another procedure. Which is usually a G-tube. The vast majority of the anti-reflux operations in the pediatric population, and that's especially true in patients under 2 years of age. The overall 30-day mortality is less than 1%, with long-term mortality approaching 4.7. and that's usually related to their secondary conditions. So their cardiac disease, their neurologic disease, all of the things that were sort of their indications for surgery. Their duration of hospitalization, their time to full feeds are also related to their other medical conditions. Reflux symptoms are thought to significantly improve in patients 5 years post-op. Dysphagia, which is present in about 13% of patients at 5 years, is more common in the neurologically impaired and patients who had a complete wrap. And then there's some interesting stuff about quality of life. And obviously we're talking about children. And so some of these things are a little bit difficult to ascertain and are based more on the parent's perception. But quality of life is thought to be the highest about 3 months post-op and then declines so that there's no difference between patients who have had an anti-reflux surgery and patients who have a feeding tube only. Quickly through some of the short-term complications. So I mentioned dysphagia, which is probably one of the more common things we encounter, and that's often due just to post-op edema and will resolve. If a patient has persistence of their dysphagia, we worry about a relative obstruction from the fundoplication. We worry about associated esophageal dysmotility that wasn't identified pre-op. And then if they have those things, we have to consider doing things like esophograms or contrast studies to look for obstruction or look for food impaction. Other short-term complications include things like wound complications, which are going to be much more common in patients who get a G-tube placed. We can also see pneumothoraces, especially with the laparoscopic approach, because we're up in the hiatus and can actually go through the pleura. And then rare but serious complications include things like injury to the esophagus or to the stomach and a leak. You can also see splenic tears during these operations as we're taking the short gastrics down. Some longer term complications, and these are the ones that parents tend to complain to us about, are things like gas bloat syndrome, which involves this crampy, vague abdominal pain, subjective sense of distension with or without nausea. And this is, again, poorly defined, and symptoms are often managed just by slowing feeds. Recurrent GERD is the most common in the setting of dysphagia or esophageal dilation or dysmotility. And of patients who are on medical management of GERD pre-op, 76% will restart their anti-reflux medications within 1 year post-op. This is going to be more common in the neurologically impaired patients, and I think a lot of that is because of the non-specific nature of the symptoms and not being sure what their experience is. Recurrence, oops. Sorry. The other things that we worry about are things like mechanical failures, which can be the lapness and herniating, a herniation of the wrap through the hiatus, or dehiscence of the wrap, or slipping off the esophagus, and all these things can be readily identified in upper GI studies. I'm going to skip these outcome ones and just briefly on the feeding tubes. So Shelly mentioned these feeding access, obviously indicated for patients who can't maintain adequate caloric intake or hydration. And there are a lot of different reasons for this and a lot of reasons that you guys are very familiar with. But our options include short-term oro or naso-enteric tubes or long-term surgical or endoscopically placed tubes. When we think about workup for patients who need feeds, like I said, the big thing that we think about is how long are they going to need this? And then once we've decided that they need to be that they need feeding support and can't go home with a NG tube or an NJ tube, then we think about the options. So in a patient who is not tolerating gastric feeds, we go through a little bit of a workup to figure out why. And a lot of that is stuff that Shelly talked about, figuring out if it's reflux or if there's some other motility thing. Upper GI is an area of controversy that we won't get into, but we will often recommend it for patients with cardiac disease who have a slightly higher rate of intestinal rotational abnormalities, or indicate for patients who can't tolerate gastric feeds to help understand why. And then if we decide that they need a tube, there's a couple of different techniques that we think about. There's percutaneous approaches, which are slightly less common in the small kids, just because, again, we're talking about the size of instruments that we have available and the types of tubes that we're putting in. So for the percutaneous or the PEG tubes, a lot of times this is that push-pull technique where you introduce a needle and a wire through the stomach while the gastroscope is in and the stomach is inflated. And then you're grabbing that wire with the snare, pulling it out through the mouth, and then pulling your tube back through. And this is sort of not recommended or contraindicated in small patients, just because if you're dragging that tube, which usually has like a rubber mushroom on it, through the GE junction in a small patient, you can cause damage there. The other thing that we worry about in small kids is that with their tiny intestines, it would be very easy to have their colon or something get stuck between the stomach and the abdominal wall. And when we do this in adults, we rely on things like a light reflex and thinking about the depth of the abdominal wall to tell us if there's something in the way. Some advantages, especially in the older patients, is that you can avoid general anesthesia in adults or in some of your older patients, and you're not actually entering the peritoneal cavity. But again, less common in children just due to the restriction of the instruments and then the high risk of injury to other things. One thing that I'll often do is take a picture of the liver when I do a G-tube on a small kid, just because I think people forget or don't think about the fact that that left lobe is really sitting over on the left side of the belly, and it would be very easy to put a G-tube right through it if you weren't looking at it. So when we do surgical G-tubes, there's a couple options. Sometimes we'll do it open. Usually this is a small midline upper abdominal incision, make a purse string around the stomach, put some anchoring sutures, and then place the G-tube. More commonly, we'll do it laparoscopically. You can do a lap-assisted stam where you're doing those same anchoring sutures to the fascia through your small incision, but you also have a camera. And then we have two different techniques that we do for the laparoscopic. One is with these buried sutures, one is with sutures on the outside. And then in the bigger patients, we also have T-fasteners and other devices that we can use to help the stomach stick up. And then lastly, the gastrojejunostomy tubes. So these are patients who either have reflux or for some reason aren't tolerating gastric feeds. A lot of them will have gastric outlet obstruction or gastric emptying impairment. And so it's beneficial to have a way to empty their stomach while giving them their feeds. These are also commonly done in patients who have had gastric or duodenal operations. I like these because they're reversible. So you can turn it back just to a G-tube once their reflux improves. And we can do these primarily lap assisted or put in a G-tube and have it converted to a J later. There are also primary J tubes, which are a little less common in the pediatric population, but sometimes they're needed after complex operations or reconstructions as an alternative to parenteral nutrition. These aren't great long-term options, and there's a bunch of different techniques for how these can be done that we won't go into. And I am so sorry for the time, but as I think you've heard in both pieces of this, GERD is very common. Some of it is physiologic and can be pathologic in our pediatric patients. There are a lot of non-op management strategies in the absence of life-threatening complications that should be attempted. Laparoscopic fundoplication is safe and reasonable procedure in the right patient population. It is not for everybody with reflux. And the long-term durability and outcomes are therefore largely tied to the underlying medical conditions, and that includes their morbidity and mortality. And I think the highlight of this whole symposium is that the early engagement of a multidisciplinary team is associated with improved outcomes and is probably the most important piece to managing any of these patients.
Thank you, Sarah. That was very informative. You get to do lots of cool stuff as surgeons. So we have a few questions in the chat, and I think the first one really goes to you, Choudhury, and it's from Anne, and she asks, without the pH studies, what can guide us to diagnose non-acid reflux? And then the second question that we have, I think this one would be to you, Sarah, and it's, do you routinely do laryngoscopy for children with tracheoesophageal fistulas or esophageal atresia prior to surgery? And if so, do you do both laryngoscopy and surgery at the same time? I guess this is because this is from Robin. We have been talking about this because we're thinking about what our pediatric airway team would be like, aerodigestive team would be like. And then I have a question that seems like an elephant in the room for me. Who gets to do the upper GIs in the children? Is it the peds GI? Is it the surgeons? Who gets to do this?
To do the endoscopy, you mean?
Yes, the diagnostic one.
So we do when I say upper GI, I'm sorry, I just mean a contrast study. So we get those in the cardiac patients before they're G-tubes to look for malrotation. But most of the diagnostic endoscopy done here is done by the gastroenterology team, which is interesting because in our general surgery training in the United States, we all get certified in endoscopy, but we, as pediatric surgeons, partner with our pediatric colleagues for most of that. In the tracheoesophageal fistula patients, we all do our own rigid bronchoscopy and laryngoscopy at the time of surgery, with the idea being looking for clefts and then also looking for the fistula. In patients who have recurrent issues, or if there's concern for recurrent fistula, or they're having ongoing respiratory or eating issues, then we'll engage with the ENT team to do sort of a better evaluation to look for cleft. Yeah. And then I think, Shelly, that question about diagnosing reflux is fantastic, because I'm asking that question all the time when I get called to do a anti-reflux procedure and
I think
want to understand.
the only tool we have is the impedance pH probe, and that's also not feasible all the time sometimes because parents consider it invasive. The child cannot keep the tube in place, so there is so much barriers to it, even if you have the instruments and the setup for someone to read the study. I think from the ENT perspective, that's why I had that picture of the laryngopharyngeal reflux. If they see anything that's red, the child will get acid suppression or PPI and just see like if there is any symptomatic improvement or not. And that's why probably like there is not 100% success when those kids go on PPI, because maybe majority of it is non-acid. But a lot of the articles do suggest, even though it's not recommended, to see if there is symptomatic improvement with PPI or not.
Sorry, I don't know if we skip this question. How do you diagnose if you don't have a pH, if you don't have manometry? So in our setting in Uganda, I don't think we have that. So one person actually asked what we could use to guide us. Are there any patient questionnaires that we could possibly use? Is there something that we can depend on, because we don't really have anything?
Yeah, I think if in the instruments or that procedure part, if there is a limitation, then you can implement the infant reflux GERD questionnaire that one of the studies have looked into. Although again, there is a lot of overlap, and you know, like Sarah pointed out, in the neurologically impaired population, it's becomes very subjective. But I think if there is no procedural capabilities or availabilities, then that will be the way. And again, I'm trying out empiric acid suppression and see if that works or not.
Thank you. I think this was a follow-up study for you, Sarah. For TOF or EA patients, when do you do the endoscopy post-surgery?
That's a great question. And we've been talking about this a little bit because there's some controversy and some differences in what's published in like the gastroenterology literature and what's been practiced in pediatric surgery. And so what seems to be our practice is that as they're coming off their PPI, most of them will get an impedance probe. They'll get some objective assessment of their degree of reflux. Most of the time we'll stop their PPI within a year, a lot of times closer to 6 months, but most of our patients end up on a PPI for a year, and then as they're coming off, they get the impedance study. And then when they become a teenager, so around 12, 13, is typically when they get their first endoscopy. And then depending on the findings in that, we'll sort of set them up with a surveillance schedule. They're not getting yearly endoscopy by any means, but if they have any evidence of metaplasia or changes, it's good to know then. And I think doing that as a teenager also engages the child in the process a little bit and helps them be aware that this is a significant thing. And I think like with a lot of things we deal with in pediatrics, it's out of sight, out of mind. And it's really easy for people to forget that these are ongoing things and that they're not normal. Even if they can eat and drink normally, they need to know this for their whole life because they are at higher risk of cancer.
Okay. I think that was all the questions in the chat. I have two more, sorry. I just have two more questions. I'm curious to know your view on PPIs and the long-standing side effects. Like some people have queries about bone fractures for taking PPIs for a long time. So my question is, how long is too long? And are there any other are there newer alternatives that don't bring about this kind of side effect? And then the second question, just for the setting that we're in, for the post-caustic ingestion esophageal strictures, what kind of approach do you use if, apart from the bypass and putting a G-tube, what kind of approach would you use to manage such patients? Would you, and after how long? Lots of questions going on in my mind. I'll let you have it.
Yeah, for the first one, I think most of the literature started from the adults where, the adults have been on the PPI for months and months and years. And now the newer studies from pediatrics is also kind of looking into that. But first, all the, like you said, the bone, kidney, and the gut microbiome. A lot of it is done on the gut microbiome is like a from the children's point of view. But I think, yeah, I mean, what they have looked at, the exposure has been for more than a year. I'm not sure if any newer pediatric study had like anything less. That will be something I have to look up. Yeah.
Thank you. Any thoughts, Sarah, on the esophageal strictures?
They're terrible. No,
Agreed.
I mean, I think I don't think that we have good answers. I think that we do a lot of dilation. We try various injections, Kenalog and things. There's some people who will try to use different stents with biologic coatings and other things on the stent with variable success. We really try to do everything we can to avoid esophageal replacement. If it's a short stricture and they have failed multiple dilations, then that's something to consider. But in patients with really severe caustic injury or ingestion related strictures, they'll oftentimes get a G-tube pretty early in their course so that you have time. You have the luxury of being able to dilate it multiple times and take your time. If it's short strictures, resection and a primary anastomosis is an option. But beyond that, or when you're talking about revisions, then things get quite complicated, and none of the replacement options have fantastic outcomes. We talk about using the colon, the stomach, in patients who have adequate stomach, and then doing small intestine sort of free flaps. And again, none of the long-term outcomes are what we would hope for. So yeah, leave it at that. We kind of take it at a case-by-case basis because we don't have a right answer, I think.
Yeah, it's one of the challenging ones. I do not see any more questions in the chat, and no questions in the chat. I do really appreciate your time, Sarah and Shelly, for giving us your expertise and answering our questions and being on this call very, very long. Thank you so much. We do hope that when we come back knocking at your door, you'll embrace us with open arms. Thank you for being part of this wider engagement, really, for us to see and think about pediatric aerodigestive care as a team. For me, it has been a very nice learning avenue because we don't really get to see much of these, and it's challenging in our case, especially with the GAD, like you've talked about, Shelly, and it's nice to see that there is something that can be done surgically. So I would possibly come back for more talks, especially because you skipped through some of the really important stuff. So thank you so much for being part of this talk. Oh yes, and Leah is saying thank you both for this depth talk. I learned a lot even while running around on call today. We're really grateful. Thank you. And we also want to thank Mending the Kids for being here. So just a wrap up from us, we will have the next talk 2 weeks from now, and it will be pediatric anesthesia in pediatric aerodigestive care. So at least we'll be able to get their input as well. Thank you so much to the attendants. We really appreciate you coming in to join, and we hope that we'll continue fostering community and collaborations and engaging with each other. Have a good night and a good morning to you both.
Thank you for having us.